Hello, everyone, and thank you for joining our virtual infectious disease grand round. We are honored today to have Dr. Zahir Usman Al-Tayyib Babikir with us today, who will be sharing his expertise on cognitive bias in medicine. Dr. Babikir is a distinguished consultant physician in infectious diseases and tropical medicine at Sheikh Shakhbout Medical City in Abu Dhabi. Dr. Babikir is duly certified in infectious diseases and medical virology and brings extensive experience in clinical care, research, education, and leadership. He is a fellow of the Royal Colleges of Physicians of London and Edinburgh and the Royal College of Pathologists, UK. He trained at the London School of Hygiene and Tropical Medicine, earning a diploma in tropical medicine and a master's in public health as a Chevening scholar. Early in his career, he worked with Doctors Without Borders in Sudan, gaining valuable experience in tropical medicine. Currently, Dr. Babikir serves as the acting chair of the Division of Tropical Infectious Diseases, chair of the Antimicrobial Stewardship Program, and the director of the Infectious Diseases Fellowship Program at Sheikh Shakhbout Medical City. He is also an adjunct clinical professor at Khalifa University and previously held an honorary senior lecturer position at Queen Mary University of London. His research focuses on antimicrobial stewardship, digital health, tropical and migrant health, emerging infections, HIV, viral hepatitis, and infections in immunocompromised individuals. Please join me in welcoming Dr. Zahir Babikir.
Thank you, Izzeddin, for the introduction, and good evening, everyone. Assalamu alaikum. This talk is inspired by a recent encounter with an orthopedic physician who was asked to see a patient with MRSA bacteremia complicated by endocarditis with septic embolization into the lungs. He also had swollen elbow and knee, and he was failing to eradicate MRSA from the bloodstream despite achieving optimal vancomycin levels, and he had to go into salvage therapy with daptomycin and ceftaroline. And the outcome of the assessment was this patient has reactive arthritis, no need for any washouts or any further surgical intervention. So that made me reflect on why we take different perspectives when we're seeing the same kind of clinical scenario. So that kind of rekindled my interest in cognitive bias, which first sparked of a few years ago, having had conversations with my ex-colleague, Prof. Mike Miller, who was interested in the subject, and we had numerous conversations about it. So I thought I should look at it properly and maybe share the outcome of my research into it, and also get your perspectives. I'm sure all of you have had similar experiences. So without further ado, I'm going to share with you an outline for this talk. I'm going to talk about diagnostic errors and how they impact clinical outcomes. I'm going to talk about decision-making process and explain the models that are coming into play, and talk about cognitive bias, define it, and show you examples of cognitive bias that we see day in and day out, and how we can mitigate for these biases. And then I'm going to give you a summary. Please feel free to interrupt at any point in time if you've got something you want to share, and let's make it interactive. So I'm going to start with a couple of scenarios and then explain the key issues. So the first scenario is about a woman who developed dyspnea a couple of days postoperatively, seen by a physician who assumed that she had pulmonary embolism. However, this physician overlooked the simple fact that she had pulmonary edema, given that she is slightly elderly and had some cardiac issues. Second scenario, which is maybe more familiar to our specialty, a young man coming into ED with fever and sore throat and cervical lymphadenopathy, given a simple diagnosis of bacterial pharyngitis, but a key diagnosis of HIV seroconversion was overlooked. So errors in healthcare, diagnostic errors really are significant contributors to malpractice claims, reaching up to 70%. And errors in the outpatient practice often stem from cognitive bias that is driven by a myriad of factors. And when malpractice investigations are concluded, they often arrive to the point that cognitive biases and reasoning errors were the main underlying reasons for the error that took place. And these errors that we see in clinical practice are not always due to knowledge deficits or gaps. These are usually due to inappropriate reasoning. And therefore, I think it's imperative for all of us to have a deeper understanding of how we think, how we make decisions in our clinical practice, and how cognitive bias can often confound these decisions. So the clinical decision-making process is explained by two key models. The first one is called the dual process model, which I will explain. And then we've got the adaptive expertise model, which kind of also leans a little bit on the dual process model, but it has a different take on the decision-making process. So let me start with the dual process model. So basically, when we are making decisions, we are using two systems, System 1 and System 2. System 1 is quick, it's intuitive, heuristic-based. This is a rule of thumb. This is a thing that you recognize by, seeing a certain pattern. So these are effective, efficient. However, it makes us, open to or prone to errors. And they're very helpful when you have to make decisions in emergency situations. System 2 is more analytical, more reflective and logical. However, it's slow, and it has lower kind of risk for bias, but it requires conscious effort. It requires awareness, self-awareness, to navigate the specific problem and arrive to the correct conclusions. And it's very useful when you are facing a complex clinical scenario. So this is when we kind of say we want to go back to the drawing board and then examine everything carefully and leave no stone unturned, kind of thing. So diagnostic errors usually occur when we solely rely on System 1, on this heuristic-based kind of system, this rule of thumb, this pattern recognition kind of system. And we don't use System 2 to validate our decision. And System 2 involves an interesting process called metacognition, which is very important in making us more aware of our own limitations and also kind of regulates our own thinking. So this dual process model is the current paradigm that kind of explains how we make clinical decisions in day-to-day clinical practice. On the other hand, the adaptive expertise model kind of complements the dual process model. However, it aims to achieve a balance between efficiency and this creative type of approach to problem solving. And it kind of classifies the users into a routine expert and an adaptive expert. So the routine expert can be any physician at any level of training. But this individual appropriately using their knowledge to solve, kind of common straightforward problems very quickly. So this is the routine expert. The adaptive expert is someone who takes it, to a higher level. They have more complex conceptual, frameworks to try and understand the problem at hand, and they reflect and try and come up with novel solutions for both complicated or unfamiliar kind of problems. And this kind of iterative process expands their knowledge and also deepens it, and makes them kind of more rooted into reasoning, and enhance their ability to solve problems, even the ones that are completely novel, not encountered before. So just to recap, there are two models that are attempting to explain how we make clinical decisions. The first one employs System 1 and System 2. System 1 is for your rapid heuristic-based rule of thumb type of scenarios that you arrive to a quick decision based on pattern recognition. System 2 is more complex, involves reflection, and requires self-awareness, and it's much more helpful in terms of analyzing complex problems and help the physician arrive to the right conclusion. Whereas the adaptive expertise model, it just asks you as a routine expert to correctly apply your knowledge to a specific clinical scenario. And these are usually straightforward, uncomplicated type of scenarios. And as an adaptive expert, you're someone who reflects on these routine occurrences, and by doing so, you create novel solutions for complex problems. And the more you do it, the better you get at it. And this again aligns with the concept of metacognition that is employed in the dual process model. So what is cognitive bias? So cognitive bias is a systematic error in thinking that kind of confounds your decision making. It's very common in clinical practice. And as we mentioned earlier, it is responsible for the majority of diagnostic errors, almost up to 80% of those errors. And these errors are often due to simply failing to consider a simple yet correct diagnosis. So what are the consequences of cognitive bias? Treatment is often delayed or maybe inappropriate. And by doing so, you increase healthcare costs through requesting maybe expensive, unnecessary investigations, or prolonging the patient's hospital stay by giving them unnecessary treatments. And this will lead to some misgivings among patients, and therefore erodes the trust that should develop between patients and doctors. And obviously there is a risk of litigation. So cognitive bias has got significant consequences. I recently attended a medical education workshop, and one of the speakers was talking about the fact that inappropriate clinical reasoning is the third most frequent cause of death, actually, based on some American data, North American data. So it's important to think appropriately in a clinical context to arrive to the correct conclusion and do the right thing. So here I think I want to have more participation from your side. I want to give me examples from your own practice. I think reflection, as you've probably heard, so far, is quite important in this debiasing, kind of approach. So we are all familiar with anchoring bias. So basically, a physician sticks to an initial diagnosis despite emerging, evidence suggesting that the diagnosis is something else. Availability bias, you're basically basing your current clinical, impression on the last or the most recent experience you had. If you've seen somebody recently with, let's say, chest pain that turned out to be aortic dissection and you happen to kind of miss it. If you see somebody with chest pain, however simple it might be, you still can't resist the fact that this may well be aortic dissection and you feel that you don't want to miss it, and you end up requesting CT scans and costing the patient more money and making them more anxious. The Bayes rate neglect is really about the pretest probability of any condition. So if you know that the pretest probability for, I don't know, endocarditis in somebody with pneumococcal bacteremia is low, then you will not feel the necessity to vigorously pursue an echocardiography on that particular patient. And the same applies to other conditions. For instance, if you think that the pretest probability for, I don't know, malignancy in certain situations is low or high, that should then guide your decision to whether or not to pursue further investigations. And confirmation bias is kind of a self-fulfilling prophecy. You kind of do your best to essentially misconstrue the evidence around you to make it suit your hypothesis, rather than challenge your initial diagnosis. When you've got new facts coming up. Also, overconfidence bias. Again, this often happens when clinicians are working in silos, that they don't get peer reviewed, during a handover meeting when they discuss their cases, or during an MDT meeting when their cases are being presented or discussed. And having kind of these meetings is an important debiasing approach. When where you get collective, opinions from different, qualified, highly qualified physicians who can, point the error in your ways or shine a light on the blind spot in your approach. Also, you often get premature closure. So immunocompromised patients tend to have, more than one disease process going on at any given time. And therefore, if you stop looking for an expression for a febrile, kind of illness, with the first, positive result, and then you forget all about the rest, then you're putting your patient's health at risk of, because you have not addressed their medical problems. Diagnostic momentum, again, this is just plodding on with the same diagnosis without reassessing new information. And the framing effect, I think we're often victims of this kind of bias, especially when you get a telephone advice, a request for a telephone advice from a colleague, and you're completely at the mercy of the information they give to you, especially if they really haven't seen the patient properly. And so garbage in, garbage out. So that your decision is completely based on the information that is presented to you. Commission bias, again, you favor action over inaction, even when unwarranted. Doctors often can't resist the urge to prescribe medications, although they know it may not be, the right thing. They just want to do something or be seen to be doing something. So, these biases are these are just examples. These are not an exhaustive. This is not an exhaustive list of all cognitive biases, but these are the ones that are frequently encountered in clinical practice, and I'm sure all of you have got something to say about this kind of biases. Now, how can we mitigate cognitive bias in our clinical practice? So I mentioned metacognition, so it's all about reflection, really. And reflection is something that is probably alien to our culture. We don't really tend to reflect, and maybe we don't really, have a word that kind of seen as professional. I mean, ta'ammul is more or less a literally word rather than a scientific word, but reflection is something that is really, really valuable and something that I personally had to learn during my work in the NHS. I was never exposed to reflection during medical school, but now if you talk to medical schools in the Western world, they are very familiar with reflective notes. Even my kids in school, they write reflective notes, but we've never been taught to do that. But reflection, in essence, make you pause and reassess and re-examine your thought processes and make sure that they are all sound. Again, slowing down is something interesting. So we all use System 1 when dealing with routine, mundane type of clinical scenarios that just based on pattern recognition you can give an answer. But we should learn to switch to System 2 whenever we think there is a complexity added to the scenario at hand. And we should also always try and think outside the box and consider alternatives. And this can only come about by discussing cases with other peers who can provide useful insights. In our practice, we have a daily handover meeting where we essentially peer review each other, because each one of us will be in charge of the inpatient consult service or the inpatients that we directly look after, and therefore when we hand over the following day, we have to go through the management plans and everything is re-examined, and then you may get a useful suggestion from a colleague about something we should or shouldn't be doing, and that's kind of really helpful. It's kind of continuous learning for all of us, and at the end of the day, the patient benefits the most from this kind of interactions. Checklists, I'm not sure about them, but certainly in favor of decision aids. So we have implemented a mobile application platform for antimicrobial guidelines, and this platform has got decision support tools built in it. And for example, we used to get a lot of phone calls about rabies, exposure management. And now we've got a rabies management tool that the ED physician can go through it and arrive to the correct conclusion without having to call us at 2 a.m. in the morning. So we've got the same for beta-lactam allergies, even for delabeling, beta-lactam allergies. We've got a tool for management of pneumonia. So these are kind of, in a way, standardize your practice and also kind of adjust for any cognitive bias that may arise from any given assessment to patients presenting with this kind of clinical scenarios. Training and simulation. Again, simulation is fairly new in this part of the world, at least. But talking to residency programs and fellowship programs that use simulation quite a lot, like critical care and even internal medicine, they said it improves their understanding of, a few things like, for instance, how to run a cardiac arrest scenario, how to deal with certain emergencies in a controlled environment, that kind of give them the confidence to deal with the real thing when it happens. So again, it kind of standardized practice. It gives opportunity for feedback and corrective action. So just on the same vein, for clinical teams, I think case reviews, as I mentioned earlier, handovers or MDT meetings, give an opportunity for us to cross-examine each other and give constructive feedback that kind of highlight any blind spots or any cognitive biases that we may have being trapped into. And such conversations I personally find helpful. They kind of promote a culture of openness and promote reflection. And also, for complex cases, it's often useful to just go back to the drawing board, start afresh, leave everything that you've done so far and just go back to basics and start from scratch. That's very useful. For hospital kind of interventions, I mentioned decision support tools, and there's good evidence to support that these are actually quite useful in reducing the risk of bias. And also training on clinical reasoning. And now, this is not well embedded into medical school, and therefore reasoning is often fairly poor. Sometimes you see it when residents or interns present a case, and then when you ask certain questions as to how they interpret the physical and investigative findings and how that links up to the history, you find everything just falls apart. There's no good, reasoning. But certainly, this is something that's, worthwhile in terms of investment. And collaboration with between physicians, between nurses, and across teams is really beneficial in terms of reducing the risk of cognitive bias. In terms of recent developments in clinical practice, we're seeing that safe communication is more and more encouraged. We have a speak up policy, and people are encouraged to speak up when they see there's something wrong. If somebody's taking the wrong route based on maybe inadequate information or misinterpretation of a test result or something like that. And also as healthcare professionals, I think some people do struggle with uncertainty. So one thing I learned during my virology and microbiology practice is that you have to accept uncertainty. You have to learn to deal with it. Most physicians who have no lab experience think that tests are like black and white, and they attach a lot of importance to the results. But actually, when you see things from the back end, you understand all the potential flaws or the issues that may, kind of impact a certain lab test result. And there is a move, whether we call it political correctness or maybe window redressing type of thing. There's a move to change differential diagnosis into a diagnostic hypothesis, which I think is probably more accurate because you're actually testing a hypothesis each time you see a patient. Based on the constellation of symptoms and signs, you have a working hypothesis and you order investigations to confirm or refute. Obviously, if it's refuted, you go back to the drawing board and start afresh. I think calling it a diagnostic hypothesis rather than a differential diagnosis is probably more accurate. In terms of medical education, there is more emphasis on critical thinking. So most medical curricula are moving towards problem-based learning, team-based learning, and similar kind of approaches, rather than the old didactic type of approach. And critical thinking should not be a standalone thing. It should be embedded into the medical curriculum, and we should not only target students, should also target faculty, and that should be part of their development programs. Also, we should encourage adaptive expertise through reflection, and that will hopefully ultimately help us balance efficiency and innovation in making diagnoses. In terms of system-based changes, we talked about medical curricula, and I think with AI now coming into play, decision support tool I think will probably proliferate over the next decade or so to try and just de-bias our decisions and kind of help us with objective evidence for our decisions. So as a take-home message, I think I hope I conveyed the message clearly that critical thinking is really vitally important, and we need to be trained at various levels as a student, as a physician, during our various stages of professional development. And also we should all be aware of cognitive biases and try and improve our diagnostic accuracy through these de-biasing approaches. I talked about reflection. So this is metacognition, so improved self-awareness and also regulation of one's own thoughts, and following a structure rather than just heuristic type of approaches. And then these can be quite effective in reducing diagnostic errors. And I think we need to understand a bit more about cognitive biases and the kind of education interventions that we can deploy to reduce the risk of cognitive bias. These references I found really interesting. The first one is about critical thinking and how it links up with cognitive bias, with the ultimate goal of reducing diagnostic errors and improving patient safety. It's worthwhile reading. The second one is kind of more detailed account of cognitive bias with lots of examples of cognitive bias, so worth a read. With that, I'd like to thank you for listening, and I'm more than happy to listen to your questions and also your comments. I think your perspective will be extremely valuable, so please feel free to chip in. Thank you.
Thank you, Zahir. That was very informative and really good. I will start with with a question. If there's any like evidence-based or any methodological way that people can look at, their cases, previous cases, or any way to see how you can, if you're not, how to diagnose yourself with having any of these biases, how to recognize these biases in your own practice while you see cases every day. What is a simple or easy way to figure out you are involved in these biases to begin with?
Sure. Metacognitive strategies or approaches, which is essentially reflection. So reflection is really, really powerful tool. I think it's grossly underestimated, especially in Middle Eastern cultures and other cultures, non-Western cultures. But it's a very powerful tool to help us revisit, a certain thought process and see where the flaws were and how best we can, rectify this when confronted with a similar scenario in the future. I mean, all of us have committed a medical error at some point in our career, and I think it's worthwhile reflecting on those errors and identifying areas for improvement and so forth. So in the UK, doctors undergo appraisals and revalidation. And as part of your revalidation, you're meant to reflect on your practice, and that's actually encouraged by the General Medical Council. So reflection, I think, is grossly underestimated, and that's one way of actually kind of conducting a self-examination of how thorough or how rigorous our thinking process is. The second thing which I would recommend is have a way in which your clinical practice is open for constructive feedback from colleagues. We run a proactive bacteremia service and other sets of proactive services, and we have a daily handover meeting. It's usually a busy one, but usually all consultants are very keen to attend and contribute, and the fellows or the residents present the cases that were kind of discussed with the consultant during the previous day, and therefore for the other consultants, this might be a completely new case because yesterday during their time they were in clinic or having admin responsibilities. They were not involved in those cases, and therefore when they're presented, that gives an opportunity to try and rectify maybe things that I forgot or my colleague forgot, or maybe a new information comes to light that will make us adjust a hypothesis. It's really good for patient safety, I think. It's not done widely, but I think it's quite useful. You can also do it through M&M meetings and stuff like that, assuming that there's no blame kind of culture. So I think reflection and also working collaboratively with learned colleagues, whose main focus is really to do the right thing for the patient, and through that give opportunity for others to learn and reflect.
Thank you. I think Wifaq has a question. You can unmute yourself.
Hi everyone. Actually, it's not a question; it's a comment. And first, before I did my comment, I want to welcome Dr. Prof. Musa Mohammed Khair, who is my teacher in the medicine, and really it's an honor and a pleasure to be in between us. I'm happy. I cannot see I cannot believe my eyes when I saw his name in the chat, and it gave a lot of nice memory in my mind. Number two, it was a great presentation, and during his presentation, I was like thinking what happened to us. We have a typical scenario of anchoring bias. I will just briefly tell the story and see how every thing Dr. Zahir has said is really a reality in our practice. When we have a child who has, she's like 8 years old and she has an open fracture that complicated with osteomyelitis. She has a very family issue that her parents always refuse the antibiotic. So she has been treated for a long time as chronic osteomyelitis with the presumptive certain organism, although it was a negative culture, but they thought that the issue that she got with this chronicity because the parents reluctant to take the antibiotic, and there was a lot of issue back and forth between the family and the hospital. But the issue, it was a negative culture, and eventually after a long period of treatment, she ended to be like TB osteomyelitis. So the negative culture and the anchoring bias came from that doctors believe that the patient didn't give the antibiotic for the child. That's why she was not treated, and no one thinking about TB at that time, unless when she went like to very long course of 3 months of antibiotic on and off between the family and the doctor. And this is typical of anchoring bias. If we are like really away from the bias from the start, like putting the differential diagnosis of a negative osteomyelitis culture, then tuberculosis would be number 1 in our differential. Thank you.
Thank you, Wafaa. That's really useful. Just by just following the same kind of approach, we recently had an encounter with one of our neurology colleagues. Apologies. They were seeing a young chap with what sounded really like Guillain-Barré syndrome, no foreign travel whatsoever, and they're very fixated on requesting Lyme serology. Now Lyme disease doesn't exist in the Middle East unless you travel for a holiday in Southern Europe or North America and come back to us with it. So we explained to them that this is not necessary. You'll be wasting money if you ask for it. But nevertheless, they ended up requesting Lyme serology, which came back obviously negative. But a good example of, failure to acknowledge the base rate or the background prevalence of certain conditions, and having this kind of irresistible urge to request a test despite knowing that the chances of this diagnosis are very limited. Ahmed?
Assalamu alaikum. Thank you, Zahir, for this informative lecture. Really an excellent topic and a very difficult topic. I believe it is because first start with our acknowledge that we have bias in ourselves. So to take this topic and to try to convince physician that really you need to pay attention to what your practice and what you've been doing, it's really a challenge. Here in US, we had that, and I think we had it in different ways. And to me, it is just I feel it has something to do with your background sometimes, right? If you practice in this certain ethnicity, they have certain disease, certain disease endemic in certain area, and this is a way that we learn. Like this, like for us here in Michigan, histoplasma is endemic disease, and left and right histoplasma. Even I call it the TB of US. And and everyone comes in with some certain features suggestive of like nodular lung disease or taking some biologic or something, then I have to keep that in my top differential diagnosis. But sometimes I feel like, yeah, that it is, but the other diagnosis is still in the differential. So, and this is one part. The other part is here in US, you've been pressurized by the, you need to move on. Patient need to get out of the hospital. We need bed, you need to move on. So kind of, okay, this maybe you need workup as outpatient. So kind of, you find yourself, you don't have enough time to figure out everything. You will start with what you think is likely. And that might be, is that considered to be also a bias, Zahir? I'm not sure, but I feel like that's one of the way that, I don't know, we learn it this way. This certain ethnicity, they have that disease. These people comes from this area, they have that disease, and that is the first thing. And then if we have time, then we'll start to think about the other. So yeah, thank you for taking us through this, Zahir. And I think, I don't know if the mortality and morbidity conference is a way of navigating that issue also. And usually we do it, but we don't put it as, we don't put the bias that we have it as one of the way of like what went wrong on that case or what went wrong on that certain scenario. Thank you very much again. And just I will take a moment to say welcome, Prof. Musa. We're happy to have you, and welcome to the group.
Thank you, Ahmed, and welcome, Prof. Musa. I think you are in Saudi Arabia nowadays, so very nice to see you taking part today. So, Ahmed, I put a slide that kind of answers your first question about the histoplasma question you raised and also the ethnicity thing. So what you're referring to is this system 1 and system 2 of the dual process model. So system 1, which is, as I said, quick, intuitive, and like rule of thumb kind of thing that tells you that histoplasmosis is hyperendemic in Michigan, and therefore you should think about it. HIV is more common in sub-Saharan Africa, and therefore people from there have got a good chance of testing positive. This is system 1. This is intuitive, this is rapid. However, it's prone to errors, as I said, because not everyone will have the disease that you are having in mind. And therefore, it's important to validate this with system 2, which is more analytical, more reflective, and kind of logical-based approach. For the question about whether M&Ms are the right forum to discuss the cognitive biases, I was recently involved in a Sentinel event as an investigator, and what was clear was that there was a strong anchoring bias that led to the adverse outcome, and therefore, they do feature in these kind of meetings. But as I said, it's important to make these events learning opportunities rather than, being used for other purposes. I would like to give Prof. Musa the chance to say hello to everyone, and then maybe you can take more questions if you guys have more questions.
عليكم.
وعليكم السلام ورحمة الله.
شكرا جزيلا دكتور زاهر. واحد يعني سعيد جدا انه سمع يسري وسمع احمد وابو بكر ووفاء ونضال. طبعا this is a very important topic. A lot of us are biased because of the spot diagnosis and depending on the experience and the epidemiological areas from which the patient is coming. But we have to be careful, as you said, and we have to not to stick to our diagnosis. Some people, they do not change their mind, have things, the feedback and the reflection will be very good for avoiding misdiagnosis and delay of diagnosis. We have people, if you remember, people in Sudan, like Prophet Dawg, late Prophet Dawg, he can stand at the door of the ward and he can spot diagnosis of 18 out of 20 patients just by looking to them. But this is exceptional, of course. I hope all people will depend on reflection and on critical scrutiny of the diagnosis so as to early diagnose and an early release of the patient from hospital. شكرا جزيلا. إن شاء الله يعني نسمعكم تاني ونتمنى لكم التوفيق والتقدم.
Go ahead, Yusuf.
Thank you very much, Dahir. That was really interesting. And as Ahmed said, it's quite a difficult topic, but you, of course, as usual, you managed to make it, like easy. And I think the difficulty in it is the fact it kind of sounds logical, but at the same time, it's difficult to explain. I think, when we go through cases in MDTs or in M&M meetings, we just don't call it, bias. But actually, whatever we find can actually be categorized in one or another of the list, the exhaustive list that you provided at the beginning of the talk. So whatever we do is probably related to some kind of bias rather than just complete ignorance or lack of training or something like this. It's not lack of knowledge, but this cognitive bias underlies a lot of the kind of mistakes, especially diagnostic errors that we make. So that's very good to kind of go through in intellectual way, the way you did it. So we have got few things. You mentioned reflective behavior or reflection, metacognition, which is fine. This is something that I can do as an individual physician. Do you think trying to tackle this as an individual, bias generally as an individual physician by learning new techniques, by focusing on how you practice, is going to be maybe more impactful than developing systems? And you touched on that when you spoke about education and that people have to be trained in a certain way that could be conducive to reduce or reduction of bias. Do you think we should really focus on systemic, collective type of effort in training, in education, and in daily practice, like what you've done? I mean, I was very interested to see, how we have got 2 MDTs a week and people busy trying to run out, but having a handover every day and with everybody sitting around is always really, in theory, very good, because I will be focusing on a point that, the person next door is not going to be focusing on. So do you think we should, from now on, try to focus on systems, on education, and in collaborative work, something that could kind of cover deficiencies in other areas, more than encouraging individual physicians to behave differently in order to reduce cognitive bias? What do you think?
Great question, Yusri. I think reflection is something that we learn. It's a learnable skill, at least for our generation. I think for our children, it's probably a bit more kind of mainstream idea because they do it since the early school years. But the way we were taught is different, and therefore we have to learn reflection as a skill as adult learners. So I think that's important, and learning will be further reinforced by writing down your thoughts, coming back to read them and, improvise or, edit or, just have more reflections on what you've written. But I think more importantly is that we put ourselves out for critique and being recipients of constructive feedback from colleagues who also value expertise and value excellence, and also they've got a keen eye on patient safety. And taking you to your next point, which is about systems, I think systems are important, and they will certainly enhance patient safety. They will kind of mitigate for some of the cognitive biases that are rampant in our day-to-day practice. And I gave an example of the decision support tools that can, to a great extent, standardize practice among physicians. And surprisingly, physicians have got a lot more faith on these tools than hearing the same advice from another doctor. So I think with flourishing of AI and stuff like that, I think we'll probably see more and more of these in our day-to-day practice. But I think the human side is quite important. At the end of the day, physicians are highly intelligent individuals. I mean, all the examples that you've mentioned, all these people who committed all these cognitive biases are intelligent, smart, competent, but this is a personal flaw. And for us to develop critical thinking skills, we have to train. If you want to be better at running marathons, you have to go to the gym, you have to run, and you have to practice to keep your level of fitness. And I think we need to do that every now and then. And discussing cases with a group of colleagues on regular basis and making that the norm kind of fosters collaborative spirit, and also learning. Continuous learning is very important.
Thank you very much, Daher, and thank you for mentioning again critical thinking. I think this is another thing that maybe people should train, or if not trained, to retrain in that area. And it's not something that is just related to diagnostics and work as a physician. It also applies to other affairs in life, isn't it? I mean, we've seen now with whatever happening in politically and in our country, and people they like to have their biases without applying that critical thinking about stuff, which would be helpful in them kind of coping with disasters. And so critical thinking is really an area that I think should be specifically targeted. And as you said before, we're not specifically trained to enhance that kind of character. And I think it's important is just like reflection, and it can be complementary to reflection.
Absolutely.
Yeah,
thank you, shukran. Thank you. Welcome, Dr. Musa. Thank you, Zahir, on the presentation. Very interesting. And it's very thought-provoking. You start thinking about, what kind of bias do I have? What kind of bias do people have? So I have two questions or comments. One of them is the Dean you already touched upon. Is like, the reflection, and you emphasize the importance of that in people in identifying their biases and acting on them. But until that happens and people are really actually doing those reflection and doing it honestly, can there be a method of we did the Myers-Briggs and the personality type, and that helped in identifying our weaknesses and strengths and dealing with other people. Do you think developing this type of questionnaires would help?
I totally agree. I personally learned a lot about myself when I went for a leadership course at Key University and had to do the Myers-Briggs, the full version. So this is as you know, it's a personality type indicator, and it kind of gives you very useful insights. And I was kind of really learning about myself in a way that I've never experienced before. That helped me enormously to recognize my areas of strength, my areas of weaknesses, and also, more importantly, help me recognize the kind of personality traits of my team mates, and help me try and get the best out of them, because I know this is something that will probably be their strength, and therefore all of us can work together and get the best out of each other and all that kind of things. I think getting to know about oneself is important, and if any of you hasn't yet done their Myers-Briggs personality type indicator test, please do it, and it's very helpful. You can also do it for your other half. It helps you enormously, and more importantly, I routinely ask, so as a program director for the ID Fellowship, I routinely ask my fellows to do it, because I think that helps me, work with you better. I share with them my 4 letters, and I think that kind of fosters a level of understanding that's good enough for us to work together without any misunderstandings, and also, more importantly, building on each other's strength and getting the best out of everyone around us. So I think the Myers-Briggs is certainly something that gave me a lot of food for thought, and helped me reflect, and also prompted me to try and improve in certain areas, also try and maybe build on the areas of strength I have, all that kind of thing. So I think it's a useful experience, and it does promote reflection.
But do you think a similar system of questionnaire can be developed to help with these biases as well?
It's an interesting question. I don't know the answer, but I think reflection is kind of case specific or situation specific, and therefore it's difficult to get a standardized tool. The examples I gave for the cognitive biases, these are just the examples. These are by no means an exhaustive kind of enumeration of the types of biases that exist, and therefore I don't think there's a certain template that can be used. I would look it up by all means and see if there is a recommended template for reflection, but I've not come across one so far. Maybe if anybody online can share with us, their experience in that regard, that would be very helpful.
Thank you, Zahir. I have a comment now. As a medical microbiologist, we're seeing, it might be part of overconfidence bias, but what we're seeing is that with the advanced technology, and I'm not saying technology is bad, technology is very good, it's very helpful. But what we're seeing with advanced technology, what we used to call in the past in a blood culture strep viridans, now has a fancy name. And people see the name and they think it's significant, and it generates a phone call to the idea, it generates a phone call for us. This is something that we see in the laboratory. And what else we see, that we see people who had bad experience bias. So they had a case where they decided that this is not significant, and they end up, turn out to be significant. And then they end up chasing every single organism that we see. So this is from a laboratory point of view, and I'm sure you see sometimes that in virology. Thank you.
Yeah, great example, yes. Yes. Yeah, certainly. I think we're often colored by our kind of latest experiences and try and compensate for our shortcomings by overreacting to something that may just be very simple and fairly innocent. And that, I think you were typing some comments. I couldn't read them. Do you mind just shouting them out?
No, I was just thanking you for the topic and putting a definition to what we've been doing, what we're doing every day. That's all. So you gave it a name, actually.
Okay, I think we're all guilty of the same thing here.
Yes, yes. You just spoke our minds يعني. Very nice والله يا زاهر, as usual طبعا. Thank you so much.
No problems.
Professor Musa طبعا برضو welcome, ويعني it was so good to hear your voice after all these years. Thank you so much for being part of this group.
All right, I think we'll come to an end, Zahir. Thank you very much for the excellent presentation. And for everybody, we love to see you also in the next month. And we need more speakers, so please, if you have any topic, cases, you need to present anything, just let us know. Thank you and have a good day.
Thank you.